Right now, I feel especially fortunate to have the privilege of introducing someone whose vision and leadership has had a profound impact not only on our center, but on the broader movement for LGBTQIA+ equity. Adrian Shanker is with us this morning, and he is the founder of Bradbury-Sullivan LGBT Community Center and the person who made this opportunity possible for us. He had the foresight and the ability to be able to work with PADOH to help us secure these funds and allowed us to be able to continue to do this good work and move forward with this project. His unwavering commitment to advancing health equity and LGBTQI+ rights have shaped policy at the federal, state, and local levels. Adrian currently leads at Shanker Strategies, a boutique consulting practice focused on LGBTQI+ health policy. He brought his expertise to the national stage as Deputy Assistant Secretary for Health Policy and Senior Advisor on LGBTQI+ health equity in the Biden-Harris administration. I think we all miss those days. He also served as a member of the Presidential Advisory Council on HIV/AIDS, and prior to his federal service as a commissioner on the Pennsylvania Human Relations Commission. Adrian holds a graduate certificate in LGBT health policy and practice from the George Washington University and a BA from Muhlenberg College. It is with deep admiration and gratitude that I ask you to please join me in welcoming Adrian Shanker to the stage this morning.
Thank you, Krista, for that very kind introduction. And I'm so pleased to see your leadership of Bradbury-Sullivan Center today. And I'm really thrilled to be here with all of you. My first time back in the Lehigh Valley for any official reason since I moved 3 years ago for today's 2025 Pennsylvania LGBTQ Health Needs Assessment, Health Summit. It's really great that this summit is now hosted by Bradbury-Sullivan Center, an organization that I'm forever proud to have founded and led for its first 8 years. And I'm thrilled to see that the organization is still working hard to promote health equity for LGBTQI+ Pennsylvanians. Before I get into my actual remarks, I want to say a word about the people who work in LGBTQI+ specific spaces. Such as Bradbury-Sullivan Center, but I know that there's many other people from different organizations around the state here today. These folks work diligently every day to support a community that's been under a concerted and unfair and unrelenting attack. And I know that there's folks from across the state who have experienced really significant attacks over the last couple years. So for everyone here who works at an LGBTQ organization in Pennsylvania, thank you for sticking with this work at a really critical time, even in the face of repeated and harmful challenges. I also want to acknowledge my longtime friend, Matt Turk. I'm so proud to see you leading Allentown as its mayor, and as a parent of a queer kid, as someone who I've known to be an ally and a champion on LGBTQI+ issues since long before you entered public service. And it goes without saying that I'm really pleased to be here with my friend and former boss, Admiral Rachel Levine. Dr. Levine and I worked together for close to 15 years, fighting for marriage equality when we were on the board of Equality Pennsylvania. And I never imagined then that she would one day be the nation's Assistant Secretary for Health, and I would be her Deputy Assistant Secretary for Health Policy. Working for Dr. Levine was a masterclass in leadership. We accomplished so much together for LGBTQI+ health. And Dr. Levine, our nation is healthier and more equitable because of your public service, your fierce leadership, or as you would prefer to say, your notorious leadership. It's hard to know what to say in this moment when it feels like our public health infrastructure has been hit by a Mack truck. After years of slow, strategic progress advancing health equity for LGBTQI+ people, we're now living through an era of health disinformation, drastic rollbacks of critical policies, and the radical politicization of the scientific process. It's led to sudden grant cancellations and data set removals. Entire swaths of the public health workforce have been fired. Entire public health offices are sitting vacant. Clinical trials have been halted midstream. It's hard to see or even imagine a light at the end of this very, very dark tunnel. While some say that these unprecedented actions will somehow lead us to a gold standard, it's more accurate to say that they'll strike fool's gold. None of this will make us a more healthier nation. The actions that have been taken over the last 5 months have undermined decades of progress. Take HIV prevention as an example. More than 230 HIV research grants have been terminated in the last 5 months. The entire Adolescent Trials Network for HIV prevention has been disbanded. The top NIH and CDC HIV scientists were fired. The research efforts to develop an HIV vaccine was ended. All civilian employees in the Office of Infectious Disease and HIV/AIDS policy have been fired. The future of the Ending the HIV Epidemic and Minority HIV/AIDS Funds grants are uncertain. The CDC's HIV Prevention Advisory Board has been eliminated, and all members of the Presidential Advisory Council on HIV/AIDS were fired. And this is just domestic HIV. The gutting of PEPFAR and unraveling of USAID are even more severe. If some of this sounds really wonky, that's by design. The people making these policy decisions want it to sound like they're eliminating duplicative and overly complicated programs. But if you take a wrecking ball into an antique shop, you're gonna break things, even the ones you're not intending to break. And that's what we're facing today. I never really imagined myself working inside the government. Most of my career here in the Lehigh Valley was as an activist. I came into this work through activism. But like most Americans, I didn't really understand the nuance of health policy or how the policies that were made in Washington or Harrisburg impacted my life directly. I knew health access was important, and I believed healthcare was a human right. But my focus was on a very narrow understanding of LGBTQI+ equity. Non-discrimination protections in housing, employment, public accommodation, safe schools, marriage equality, other forms of relationship recognition. A+B had to equal C. We could all understand how those issues directly affected our lives. And frankly, the Lehigh Valley and Pennsylvania as a whole were really far behind. I remember a moment in the early 2010s when former state representative Babette Josephs, who was known as a very liberal member of the state house, surprised all of us by bringing a vote to the House floor that would have required inheritance equality for same-sex couples when one spouse died. And I was leading Equality Pennsylvania at the time, and we didn't get a heads up that this vote was happening, so there was nobody to whip the votes in Harrisburg. That let us see the true colors of where Pennsylvania was at the time. 50 House Democrats voted against inheritance equality for same-sex couples, only 4 years before winning marriage equality in Pennsylvania. It was devastating. We used that as an impetus to create a stronger mechanism to at least keep supposed allies in check. And we worked with a few members to create the first legislative equality caucus in the Pennsylvania legislature. Today I have a very different understanding of what it means to advocate for policies that impact LGBTQI+ people. Mara Kiesling, who founded the National Center for Transgender Equality, today known as Advocates for Trans Equality, she liked to say that the most important LGBTQI+ issue is the most important issue to that LGBTQI+ person. By that she meant that housing policy is queer policy, and immigration policy is queer policy, and yes, health policy is queer policy. We just saw from Christina the updated data from the Pennsylvania LGBTQI+ needs assessment, where 4 in 10 LGBTQI+ Pennsylvanians said that violence is the most pressing LGBTQI+ health concern, and that housing is also a significant concern. Like all people living in America, LGBTQI+ people deserve to live in communities that are safe from violence, or the fear of violence, or the fear of eviction or homelessness. And as we celebrate Pride Month, the public health community should recognize that the fear of violence and housing are social determinants of queer health. One of the things I'm proudest of from my 17 years of movement work in Pennsylvania is co-creating the Pennsylvania LGBTQI+ Health Needs Assessment. This was started thanks to a CDC requirement at the time that every state Department of Health had to have a written plan to address LGBTQI+ tobacco disparities. My colleague, Dr. Scout, who currently leads the National LGBTQI+ Cancer Network, and I approached the then director of the Department of Health's Tobacco Division, her name is Judy Oakes, and I considered her to be an unsung hero of LGBTQI+ health. We offered to partner with her to address this requirement by creating and broadly implementing this needs assessment. We piloted it in the Lehigh Valley and in central Pennsylvania in 2015, and brought it statewide in 2016 before it became a biannual survey. The data collected in Pennsylvania now is a model for the nation. At a time when very few federal data instruments included sexual orientation or gender identity, Pennsylvania started to do so with its own needs assessment that was designed to complement that federal data. It's today the largest and most comprehensive multi-year data set on state-level LGBTQI+ health disparities in the nation. When I arrived in Washington, Admiral Levine asked me what were a couple of the policy areas that I wanted to work on right away. And I said two things. The first one was ending the long-standing, discriminatory, and unscientific blanket ban on gay and bisexual men donating blood, which we did by replacing it with an individual risk assessment where all blood donors are asked the same questions. And you may not know this, but Dr. Peter Marks, who was the head of the Center for Biologics Evaluation and Research at FDA until he was fired by RFK Jr. because he wouldn't undermine his own vaccine research. Dr. Marks was the FDA's lead on ending the blood donation ban, which Admiral Levine and I worked with him on for many, many months. The other issue was data equity. President Biden had signed an executive order that called for an interagency collaboration of career statisticians to develop a federal evidence agenda on LGBTQI+ equality. As a political appointee, I was not allowed to join that effort because the administration wanted to make sure that the recommendations were grounded in the best available science, not in political goals, a decision I deeply respected and admired. But one of the recommendations of the federal evidence agenda was for every federal agency to develop a SOGI data action plan, sexual orientation, gender identity data action plan. Admiral Levine brought me to HHS to lead the LGBTQI+ policy portfolio for the department, so I was tasked with implementing this and many other executive order deliverables. HHS's SOGI data action plan was forward-thinking and ambitious. Required every division of HHS to undergo a complete review of their data instruments and to consider whether and how to add in SOGI measures. We didn't prescribe an outcome. We trusted the data scientists to make the decisions with scientific integrity. So let's be clear about what data equity means. Data equity means that the data that the government collects includes all of us. It's not some woke scheme, it's precision public health and precision epidemiology. One of my former HHS colleagues liked to say, we measure what we treasure. At the beginning of COVID-19, the CDC required every state to measure race and ethnicity data for COVID infections, but SOGI data was not included. So we didn't have any way to actually know what our community was facing. We could foresee why this was a problem, and Dr. Levine, then Secretary of Health here in Pennsylvania, by the end of April 2020 had made Pennsylvania the first state to collect SOGI data for COVID infections, but only a couple other states followed. We never got national data on SOGI disparities for COVID. We will never fully know because the CDC didn't instruct every state to add those questions. And the CDC also never updated the case report form for infectious disease. So when Mpox emerged as a crisis in the United States, SOGI data wasn't on that form either. And we were without complete information at the start of Mpox about where the burden of disease existed most. This was addressed later as part of our SOGI data action plan. We can't achieve health equity without data equity. And the current administration knows that. That's why they've obsessively scrubbed SOGI measures out of every data instrument they can find. Why are they so obsessed with us? They've even removed SOGI data from already collected data. If I'm being generous to people that I disagree with, I would categorize their view as that they think that disparity data takes away from seeing all Americans inherently the same. And they don't believe in prioritizing resources based on key populations. But if I'm being true to everything I know about health policy and data policy, I would say that there are erasing evidence of health disparities to keep historically excluded and marginalized communities from achieving the unmet dream of health equity. To many of us, the cruelty is actually the point. It doesn't save the government any money by taking gender identity measures out of the National Survey on Drug Use and Health. But it does mean that we don't have any future data on how trans people are impacted by substances. To be serious about responding to opioids in our communities requires precise data, but these are not very serious people. And to paraphrase the current Secretary of Health, he doesn't think anyone should take medical advice from him. At least there's one thing we can agree on. Nobody should take advice from RFK Jr. seriously, whether he's spreading lies about the safety and efficacy of vaccines, or whether he's falsely saying that poppers cause AIDS, or when he's talking about trans kids and their providers by calling medically necessary healthcare so-called gender ideology. I presume that most people in this room have read or at least seen his 400-page anti-trans report. This report is a compilation of the best available junk science today. The report even calls for conversion therapy by a new name that they concocted, gender exploratory therapy. They drew conclusions that are not supported by their own citations. The report did not and could not have gone through any meaningful scientific review process, even an internal scientific review process. In fact, Secretary Kennedy repealed the HHS scientific integrity policy before publishing the report. When I was at HHS, I worked on a handful of reports, including a groundbreaking report on the harms of conversion therapy. We called it Moving Beyond Change Efforts because it's not conversion therapy, it doesn't convert anyone, it's not therapy. And that report took many, many months of research and even more months of layers of scientific review. I also wrote the first HHS report on the health needs of intersex Americans. I'm incredibly proud to have worked on that report. And this report was written and rewritten 13 times. It went through at least 4 rounds of very significant levels of scientific review, and it took over 2 years to publish it. Could we have moved a little faster? Sure. But the HHS anti-trans report was published in under 6 weeks and was largely pre-written by a think tank in Washington, most likely, and it read more like a campaign document than a serious scientific report. Regardless of how anyone feels about the undergirding science related to transgender medicine, which I personally believe to be quite strong, the steamrolling over a scientific process should concern everyone. I will say clearly though, and I know Dr. Levine will speak to this in more detail, the rhetoric that they are using to talk about transgender medicine is a bold-faced lie. Trans people deserve access to the health care that their bodies need, full stop. And we should fiercely oppose any hospital decisions that roll back access to care for transgender people, especially when those rollbacks are compliance in advance. Yeah, we can clap that. The attacks on trans care are unrelenting, and the anti-trans movement has taken a page out of the anti-abortion movement. They're using every tactic, including threats of violence against providers, prosecutions of providers, to try to make trans medicine impossible to access. And not just in states that have banned the care, in every state. They even turned the HHS Office for Civil Rights on its head by creating a snitch line for people to report providers of transgender medicine. By the way, medicine that is backed up by medical associations and is within the acceptable standards of care. I know that this moment feels uncertain and scary for trans people and their providers. LGBTQI+ people have always had to be our own healthcare advocates. We have always found creative and resilient ways to keep each other safe and healthy and to resource health information for each other. We can learn from the early HIV activists like Michael Callan, who created the How to Have Sex in an Epidemic pamphlet in 1983. The Buyers Clubs, who ensured access to life-saving medicine in the face of FDA inaction on HIV medication approvals. Or the ACT UP and Treatment Action Group activists, who demanded that drug companies like Burroughs Wellcome bring down the cost of AIDS medications when they were profiting off the death and dying of an entire group of people. These activists didn't follow accepted protocols. What they did was needed in order to ensure the health and lives of LGBTQI+ people. The beautiful thing about the LGBTQI+ movement is that there are people who've come before us, and we can look to their examples to find a way forward. I would be remiss not to speak about some of the progress that we worked on in tobacco policy in the Biden administration. The tobacco policy work I'm most proud of being part of was the Surgeon General's report on tobacco disparities. This was Vice Admiral Murphy's only Surgeon General's report during the Biden administration, and it was the first ever Surgeon General's report to specifically address LGBTQI+ tobacco disparities. It was over 1,000 pages with hundreds of citations, so I'm recommending it to you for your July 4th beach reading pleasure. This report was a long time coming. Scientists literally worked on it for close to a decade. And Surgeon General's reports don't disappear when future administrations take over. The science is already published, and the science in this report is clear in how the LGBTQI+ communities and BIPOC communities are disparately harmed by tobacco. In many ways, Pennsylvania is ahead of other states because of the Pennsylvania Department of Health's decade-long commitment to LGBTQI+ tobacco disparities. In other ways, Pennsylvania has a long way to go, as we just saw from Christina's presentation. And tobacco consumption is a coping mechanism. So in our current times, I actually predict that tobacco use will go up, especially among trans communities. It's up to the community, all of you, to help people find safer coping mechanisms during this tumultuous time. And we also need to understand that tobacco prevention efforts need to always really understand the communities that are most impacted. And with this, I want to talk about National Spit Out Day. So I remember a handful of years ago when I was still at Bradbury-Sullivan Center, we were responsible for celebrating tobacco-free holidays. And one of them was National Spit Out Day. I called Jamie McGee, I think you're here. So I called Jamie, you probably remember how awkward this phone call was. I politely explained that we were not going to participate in this one. And then I kind of forgot that National Spit Out Day existed until I got to HHS. And the CDC updated their National Spit Out Day campaign, which featured a college-age looking farmer standing on an open field with text that said, "Spit it or quit it." And underneath it said National Spit Out Day. I was horrified, and I called the head of the Office of Smoking and Health. I don't even think I told you I was doing this one. I called the head of the Office of Smoking and Health, and by the way, that office has also been disbanded by RFK. All the staff of that office have been fired. But I called the head of the Office of Smoking and Health, and I actually asked her, do you have any gay people in your office? Like any, at all? And she was really confused by my question. And so I showed her the ad, and she still was confused by the question, and I had to walk her through it, which was, by the way, not my favorite thing to do. And I explained to her that nobody I knew, not a single person I know, would think that National Spit Out Day was about chewing tobacco. In fact, I think most LGBTQ people don't know what chewing tobacco is, just saying. And that it was a really bad campaign. And it was not going to lead to its intended results. Needless to say, the graphic in question was removed, and I was glad to not have to explain that ad to anyone higher up at the CDC. The lesson here is to include diverse populations as reviewers in your public health campaigns. What resonates with one community, or what you think would resonate with one community, might be really inappropriate for another community. In closing, the work ahead of us is quite daunting. The avalanche of federal policy rollbacks seems unstoppable. The harm to people's lives is real. It's not hyperbole to say that people will die because of federal funding cuts and the disinformation campaigns in public health. It will take decades to rebuild our nation's public health infrastructure and trust in our public health systems. But despite the many challenges of the federal government right now, I have confidence that, like times in the past, we can continue to prioritize access to care for LGBTQI+ people, and it's conferences like this one that give me hope that so much of our collective power to one day achieve health equity is still possible by working together. Healthcare is a human right, and health equity is how we know we have achieved it. I'll close by quoting one of my favorite poets, Chen Chen, who wrote, "Let us stay tender-hearted, despite, despite, despite." Thank you.
I have the distinct honor of introducing our next speaker, Admiral Rachel Levine. As a public health professional serving the LGBTQ+ community, I could not be any more excited to have Dr. Levine speaking here today. Her work is inspiring, and I cannot wait to hear what she has to say. Dr. Levine served as the 17th Assistant Secretary for Health at the U.S. Department of Health and Human Services and led the United States Public Health Service Commission Corps. Prior to Dr. Levine's federal service, she served as the Secretary of Health and Physician General in Pennsylvania, where she led the state's response to the acute phase of the COVID-19 and opioid epidemics. She entered public service in 2015 after a career in academic medicine, including as a professor of pediatrics and psychiatry at Penn State College of Medicine. She completed her residency and fellowship at Mount Sinai, earned her MD at Tulane University, and completed her undergraduate work at Harvard College. She is a fellow of the American Academy of Pediatrics, Society for Adolescent Health and Medicine, and Academy for Eating Disorders, and served as president of the Association of State and Territorial Health Officials. Dr. Levine has been named by USA Today as one of their 2022 Women of the Year, by Time Magazine in their inaugural list of the 100 most influential climate leaders in the world, and she is a member of the National Academy of Medicine. Thank you so much for the incredible work you have done for the LGBTQ+ community here in Pennsylvania and across the nation. Now, without further ado, please share your wisdom with us, Dr. Levine, so that we may continue to build a more equitable future.
Well, good morning, and thank you so much for that wonderful introduction, and thank you so much to the Bradbury-Sullivan LGBT Community Center for inviting me to join you today. And Adrian, is there anything else you want to tell me that I didn't know? Just checking about what other things. I am thrilled to be here at the Mack Experience Center for the 2025 Pennsylvania LGBTQ Health Summit to engage with all of you in a critical conversation about public health and health equity. I am especially pleased that this important summit is back this year in person after a long hiatus that began with the acute phase of the COVID-19 pandemic. I have spoken at this summit in the past and have always found it to be an important time for statewide connections and collaboration, all in the service of health equity. You know, thank you so much for outlining my background as the Assistant Secretary for Health, as the amazing opportunity to be a 4-star Admiral in the Public Health Service Commission Corps, and then my previous time in public service as the Secretary of Health of Pennsylvania and the Physician General of Pennsylvania. You know, I really did not plan to work in government and public service in my career. In fact, I was well ensconced, as you mentioned, in pediatric academic medicine at the Penn State College of Medicine when I received a phone call after Pennsylvania Governor Tom Wolf was elected first to be the co-chair of the Transitions Committee for Health, and then to be, in January, their Physician General. But I said yes, enthusiastically, and we got to work responding to the opioid crisis, increasing childhood vaccinations, and advancing the quality of care for LGBTQIA+ Pennsylvanians. One of the biggest things that I worked on was the opioid crisis. You know, what my interest at Penn State was in that intersection between physical and mental health. And the opioid crisis was clearly that. And it was and remains very challenging for local, state, and federal public health. And is certainly an opportunity for statewide and nationwide collaboration to serve as the 17th Assistant Secretary for Health, and I took my commission as an Admiral in the Public Health Service Commission Corps. Just a word about the Public Health Service Commission Corps. It is one of the 8 uniformed services, and it is the only uniformed public health service in the world, with more than 5,500 officers in medicine and public health that serve in 800 locations across the 50 United States and territories and actually across the world. And it is an amazing service. We're not military or one of the 8 uniformed services. In my role as the Assistant Secretary for Health, I oversaw a number of program offices, including our Office on Women's Health, the Office of Minority Health, the Office of Infectious Disease HIV/AIDS Policy, and we started a new office on climate change and health equity. That has been discontinued since the beginning of the Trump administration. Each day, we worked to address the diverse public health needs of everyone living in the United States. We led key HHS policy initiatives to advance public health and health equity. And health equity, it wasn't like we added health equity on Friday afternoons. Health equity was fundamental, it was foundational to everything we were doing. And that included reproductive health care and health equity, LGBTQIA+ health equity, the health impacts of climate change and environmental justice, ending the HIV epidemic, responding to a syphilis crisis. I have to tell you, when I was in medical school, I never knew that I would be the de facto syphilis czar of the United States, or czarina, as it might be. And we prioritized long COVID research and practice. Achieving health equity requires valuing everyone equally, and we did this through focused and ongoing efforts to end contemporary injustices and strong considerations of the social determinants of health and health disparities. I firmly believe that we have not made progress. We have not really made progress in health equity unless we have all made progress. I want to take for a moment to highlight some of the strides we made in terms of LGBTQIA+ health equity. One and critical thing we did is we brought Adrian back from California, where he had moved, to Washington, D.C. To be the head of our LGBTQIA+ policy, and then actually to be the Deputy Assistant Secretary for Policy and Legislation. Adrian and I started working together in 2011. He was 15 at that time. We were both on the board of Equality Pennsylvania, and he was actually the president of the board of Equality Pennsylvania. His work building the Bradbury-Sullivan Center, leading LGBTQI+ health campaigns in Pennsylvania has been amazing, including work to make Pennsylvania's Pride Festival smoke-free, and just have worked together and continue to work together. And I'd like to thank him for his fantastic work. In the Biden administration, we finalized protections from healthcare discrimination for LGBTQI+ Americans, designated LGBTQIA+ and HIV-positive older adults as populations of greatest social need, safeguarded youth in the foster care system and the runaway homeless youth system from the harms of conversion therapy. As he mentioned, prioritized data equity with the SOGI Data Action Plan. Adrian is the SOGI Data Action guru, in Washington. And as he mentioned, safeguarded the nation's blood supply. And we finalized the first ever health needs of intersex Americans. These efforts are all under siege by the current administration. So I want to acknowledge that this is a very difficult and challenging time for us, for our rainbow family, for our LGBTQIA+ community, and for the health needs of trans youth in particular, and their families, and their healthcare providers. These political and ideological attacks are not grounded in science or evidence. Gender-affirming care is essential health care. It is medical care. Gender-affirming care is mental health care. Gender-affirming care is literally suicide prevention care. You can clap. It improves the quality of life and it saves lives. It is based on decades of study, and it is an evidence-based standard of care treatment. It is really a specific strategy from Republican and conservative think tanks in Washington to attack our broader community. After seeing that they had lost the marriage equality debate, they decided to attack what they felt, and it was true, the most vulnerable aspect of the community, which was trans individuals and non-binary individuals, starting with athletes, then youth, now obviously going to the entire trans community and continuing on if we allow them to do so. In public health, we need to stand up for the scientific process that leads to the development of standards of care, which of course evolve and change over time. Based on this long history of research and medical evidence, the overwhelming majority of professional medical organizations endorse gender-affirming care, where it's medically necessary, safe, and effective for transgender and non-binary youth and adults. The providers of care for trans people are also under unprecedented attack right here in Pennsylvania, with some worrying about their physical safety on a regular basis. And of course, the anti-trans attacks aren't limited to youth. Actually, the House passed budget bill would remove access to care for trans adults in Medicaid and reduce care in regards to the Affordable Care Act plan. So, as Adrian mentioned, the cruelty is the point. So, we all have to work together, and we are stronger together against these attacks. They are really trying to split our LGBTQIA+ community, our rainbow family, and to split the progressive movement. And we are clearly stronger when we stand together. And we have to take a stand on behalf of those who are being hurt by these attacks. Now, if someone needs a friend, an ally, or just a supportive individual, you have the power to be that person. There's an amazing study from the Trevor Project that shows that LGBTQI+ youth experience significantly lower rates of suicide when they have one supportive adult in their midst. One supportive adult. Now, we might think that that's a parent or another family member, but it doesn't have to be. It can be you. Sometimes that's all it takes. On a macro level, public health must work to continue to advance data equity based on sexual orientation and gender identity, continue to prioritize health disparity prevention, analysis, and response. As Adrian said, this is not woke, this is just public health. It is precision public health. It's population health, and it's how we keep our society safe from dangerous viruses and other communicable diseases. Now, in regards to the HIV epidemic, I started my residency program in pediatrics at Mount Sinai Hospital in New York City in 1983. We didn't know what HIV was. We didn't know what was causing these severe opportunistic infections and deaths in 1983. I watched as patients who were children passed away, their mothers passed away, some of their fathers passed away. I saw teens in adolescent medicine who died, and friends and colleagues as well. It was more horrible than you can possibly imagine. The science we have today in terms of antiretroviral treatment, ART, where U equals U, undetectable equals untransmittable, in terms of PrEP, would seem like medical miracles. But the key to really ending the HIV epidemic is getting those medical miracles to the people who need them most. That is health equity. That is the key to truly ending the HIV epidemic in the United States and across the world. And all of the advances that we have made, many of the advances are under threat and under siege at the current moment. We made a lot of strides. The FDA approved the first injectable form of HIV PrEP. The U.S. Preventative Service Task Force issued a Grade A recommendation for PrEP. CMS issued the national coverage determination to make PrEP free for anyone on Medicare. We created the I Am the Work of ART to promote adherence. And we addressed a key social determinant of health when the Ryan White program ended their long-standing prohibition on using their funds to pay for security deposits in terms of housing. I also led the syphilis response, and we formed a task force to rein in syphilis and congenital syphilis. We actually worked with Pfizer to reverse a shortage of Vacillin. We advanced access to doxycycline for post-exposure prophylaxis. We published clinical considerations to help physicians understand the rapid test for syphilis. And we worked on a health equity basis with priority jurisdictions that had the highest syphilis rates. The devastating impacts of the SOTS decision has led to a patchwork of laws in terms of reproductive health as well. And reproductive health is, of course, public health. And abortion is absolutely necessary reproductive health care. So we have created in the United States, both in terms of access to abortion and in terms of gender-affirming care, medical refugees. Medical refugees in the United States, where they have to leave the state where they are in order to come to another state, sometimes thousands of miles away, to get the health care that they need and deserve. In closing, as I have said before, we have not made progress unless we have all made progress. And we all have a role to play in making that happen. Now, you might have guessed, I am a positive and optimistic person. I am positive and optimistic because I choose to be positive and optimistic. I have my days as everybody else does, but to give in to pessimism and despair inhibits your ability to do the work and inhibits the ability of the people around you to do their work. So I think that we have to respond with positivity and optimism in regards to doing the work that is necessary to reverse these trends. Your actions, each one of you sitting here, have the power to shape a better and more inclusive world. And we often do not realize the impact that our actions have on the world around us, both big and small. The challenges of the last number of years have reminded us of a fundamental truth, that we need each other, that our happiness and our very survival depend upon our connections to one another and our community. And it is that spirit of community that we need now more than ever. There are many groups that face unique and increased risks from multiple health challenges, and we have to work to end those health challenges. I am optimistic about the future of public health, and I'm glad that you will be a part of it, because I see you all as our future. As a trusted voice in your community and as a frontline professional, you have the power to understand, educate, and respond to your community's needs. And that work in the local communities and the statewide work is so important now more than ever. We can do better. We must do better. And with your help, we will do better. Thank you very much.